see you because it's Zoom webinar, but we can see 100, 108, and the number keeps going up. So we'll just give a few more minutes for other colleagues to join. I think approximately just under 500 people registered for the event. Generally, with these events, hello, Simon, fantastic. So you can say hello in the chat. That's absolutely brilliant. At some point, the chat will be disabled, just so we make sure that you channel your questions via Slido, and Abigail will drop the Slido link in the chat. But a very warm welcome to colleagues who are not from MHCLG. Welcome to all civil servants. It's great to feel your presence. I can't see all of you, but I think it's really important for us to come together to discuss this really important topic. I'll just give it a few more minutes so we can just get as many people in. I'm probably expecting about 250, given the usual dropouts. A lot of people register for things and stuff just happens, but let's just give it a few more minutes. Thanks to everyone who has so kindly uploaded their questions in Slido. If you do want to go onto Slido, please go in. If you see a question that you like, instead of typing it over again, I think we're all used to this now, just upload or upvote, thumbs up that question. So I think we will start. Just under 200 colleagues coming in. So I'm Bernadette Thompson. I work in MHCLG. I'm a Deputy Director for Inclusion, Wellbeing and Employee Engagement. So all the stuff that makes us smile within the workplace. I also co-chair Cross-Government Race Network, Race to the Top, grade 6 and 7. So look, we thought it would be a fantastic idea for us to put this event together from two perspectives. So MHCLG, we're the Department of Communities and Play, so this is really close to our heart. Second perspective links to my second role as a cross-government co-chair. With all our colleagues who are chairs of race networks across government, it's really important for us to understand the part that we have to play in supporting the government in getting the jab in as many arms as possible. And, you know, from the BAME community, I was speaking to Dr. Grace a couple of weeks ago, and, you know, she was saying to me that, you know, these issues that we're talking about, the hesitancy in the BAME community, she said, it's bigger than this, that, you know, from a home, you know, from the whole medical perspective, that a number of people from the Black and Asian minority ethnic communities don't actually subscribe to some of the checks that they should actually attend within the hospitals or medical system. We're talking about mammograms, talking about all kinds of checks that we should really be subscribing to. So this is an event where, you know the impacts of COVID. We've seen it in the numbers. We've got some vaccines. I'm not a medical person. I am afraid of needles, but I probably will ask that question. What can someone like me do to make sure that when I'm taking the vaccine, I don't pass out? But without further ado, I'm going to hand over to Kathy. But before I do that, I'll just introduce the panel or the lineup that we've got for you today. So we've got Shivani Lakhani, who's going to be our resident analyst for today, and she's going to be sharing all the data that kind of sits at the bottom of all of the stuff we're talking about with regards to data. I know a lot of people love to see the data. We've got Professor Kevin Fenton here with us. We've got Dr. Sonia Adesara with us. We've got Dr. Grace Macaulay with us. And we've got Dr. Martin Griffith with us. So we are in the company of specialists, which is absolutely brilliant. So without further ado, I'm going to hand you over to Kathy Francis, who's our Director of Housing. and COVID-19, and the slash there I've noticed on the script I've got in front of me, to kind of set the scene for today and kind of outline why we are doing this. So over to you, Kathy.
Thank you very much, Bernadette, and welcome to everyone who's taken time to join this seminar. Let me just say a little bit about kind of my interests, personal and professional. I think obviously as a Black woman in the Black community with family members, observing the debates, are they taking the vaccine, are they not taking the vaccine? And noting that a lot of people said, Kathy, what do you think? And a lot of people in my family want to know what I'm doing, not because I'm a specialist, but these are the conversations that we have in our families and our communities. And also professionally, at around the time of the PHE reports, Kevin Fenton's reports on disparities in risks and outcome of COVID-19, in the department, with my Director General and with a number of colleagues and across the Cabinet Office task force looking at COVID across the board, we thought, what more can we do to try and make the policy machine respond more effectively to what we are seeing in the data? And so at that time, I was working on COVID-19 exclusively. I was a senior lead in the West Midlands. Some of us came together and we decided we needed to have a formal process across government with a champion, with a senior responsible officer, because that's what we do, isn't it? When things are important, we appoint an SRO. And I'm really pleased that my Director General, Emran Mian, agreed to be the champion who would take forward work across Whitehall, looking at the disproportionate impacts of COVID on different groups. And so I have tried to do my bit to support him in that role, alongside a number of colleagues in the Cabinet Office who are dedicated full-time to making sure the voice of disproportionate groups is properly embedded in our policy work through phase one, wave one, as we move through wave two, and then again, as we look to the next stages post the pandemic and look at the wider social and economic impacts. So it's really important that we approach the work that we're doing with a clinical and evidence-based understanding of what we are seeing, overlaid, really, really important this, overlaid with what we are hearing, what we are observing, understanding the conversations that are happening within our communities. That is really important. So we started in particular being very concerned, looking at the higher transmission rates in places like Leicester. We understood a lot of people were making a very, very strong and positive case for action to be taken that was both bottom up as well as top down. Professor Fenton's report articulated that very well in terms of needing to have the voice of the community into the decision-making process, into the operational process, as both the vaccine was going to be rolled out, but even before that, helping businesses, helping communities to become COVID compliant. And some of that work informed subsequent work around improving communications and engagement. And I'm particularly proud that we were able to win both support in government at a policy level, but also at a financial level to fund Community Champions Scheme, which I think is a really, really important scheme. And then there are other activities that we have supported and encouraged across government around more aggressive testing in the right place, in the right communities, working with shielded and vulnerable groups, etc. So the work across Whitehall is genuinely across Whitehall and covers all departments. So as we come through the pandemic and look to vaccines, I think our concern is that there will be some communities that will never actually emerge from this pandemic. And I think that is what today's session is about. And I'm, humbled by the work that is being done across Whitehall and that my DG is doing and the Cabinet Office Task Force is doing, but also that we've managed to get the panel together. Basically, everyone just said yes. There was no buts. There was just yes, we can do this. So I'm really grateful. And as I said, I'm really grateful to you as well. I mentioned the importance of data, knowing the data. We will come to that in the Q&A in terms of all the data that's swirling around the vaccine, efficacy, etc. But before you do anything in Whitehall, as you all know, as good civil servants, you need to understand what the data is telling you. And so I'm really, really pleased as our first presenter to introduce Shivani, who is the backbone of all the work that we have done. Very, very cool-headed, very clear, very articulate about what do we know, what don't we know, where do we need to get further analysis. So I'm not going to preempt her presentation, but I think simply invite Shivani to come forward and present the data, which will be the beginnings of our session this evening, and a really, really important contribution that we were keen to include in this presentation. So thank you all again, and thank you to Shivani, who's about to come forward and present.
Thank you very much, Kathy, for such a lovely introduction. Let me share my screen and then I can make a start on the presentation. So hopefully you can all see that now. Great. So as Kathy mentioned, I'm an analyst in the COVID-19 task force, and the team I work on, it's our job to understand how the pandemic has impacted society. And my particular area of expertise is kind of understanding which groups have been disproportionately impacted. And that's why I'm speaking to you today about ethnic minority communities and how they've been impacted by COVID. So to start off, many of you probably remember in the news, sort of towards the early parts of summer last year, there was a lot of media attention on the fact that ethnic minority groups have been worse impacted by COVID. They're more at risk, I think, were some of the key headlines. Up until that point, data and analysis on COVID-19 and ethnicity was really limited. It was really difficult to get a hold of, and there was no one clear narrative on what was happening and why groups were disproportionately impacted and how much they were disproportionately impacted. And so what we did is we kind of worked really hard to get a lot of data from different parts of Whitehall into one single coherent story. And we kind of relayed that back up to the Prime Minister, to cabinet ministers and to senior leaders across government to tell them exactly what was happening and why. And those are some of the things that I want to take you through today, whilst also linking it back to the reason that we're all here to understand a bit more about the vaccine and its importance. And so, yeah, I just wanted to start off by saying that particular point signaled a step change in the way that government looks at equality and looks at equalities analysis. Great, so without further ado, let's get into the presentation. The first point, and kind of bringing it back to the vaccine, there's a lot of scientific evidence, and most of the scientific evidence says that the most effective and proven way of reducing hospitalizations and deaths is by getting a vaccine. And then when we think about which groups have been hospitalized more as a result of COVID and have died disproportionately as a result of COVID, ethnic minority groups are up there. So the rate of hospitalizations and deaths among these communities have been particularly high across the pandemic. And that's why it makes it even more important for these communities to get vaccinated. And then the evidence that I'm going to take you through now will kind of highlight how much more at risk these groups have been. And it will also kind of touch on some of the reasons why that has happened. So first, I keep saying that ethnic minority groups are more at risk. What do I actually mean by that? And a good way of understanding that is by looking at the cases per 100,000 of the population by ethnic group. And what we've got here is the picture of that for basically the whole of the pandemic. So it starts from about summertime last year and goes right up until sort of the early parts of March of this year. So the first thing to focus on here is that yellow line. The yellow line represents the white group. So that is cases amongst the white community throughout the pandemic. The first thing to note is that pretty much all ethnic minority communities have had considerably higher case rates than this group for most of the time period that you're seeing on there. One of the first things I wanted you to focus on is that really, really high peak towards the end of last year. That's what everyone keeps calling the second wave. And what's important to note here is whilst case rates increased quite rapidly for every single ethnic group, they increased at a particularly alarming rate for ethnic minority groups, especially the Black groups, Black communities, the Indian, Pakistani, and other South Asian communities. And just to give you an example, earlier on in the year last year, there were points at which the case rates for the Pakistani community were over 3 times higher than they were for the white group. And so that's what we talk about when we say increased risk. Cases and transmission have been much more prevalent in some of these ethnic minority groups. Unfortunately, those case rates have translated into higher death rates amongst these communities too. And that's something that's been in the news quite a lot as well. And so I kind of wanted to take you through some of those bits of data too. So what we've got here on the left is the death rates for men in the first wave of the pandemic, so from January to August last year. And what I've done here is kind of looked at each ethnic minority group and compared them back to the white British population. So any of the bars that are on that same rate line show you that the death rate is at the same rate as the white British population. And I mean, I'm talking to you about men here, but the story is very similar for women. It's just the death rate for women is much, much lower. And so I wanted to illustrate the point by using the male death rate. And so what you can see from the first wave here is that pretty much across the board, every single ethnic minority group had a much higher death rate than the white British population. And to kind of pick out a few examples here, if you're looking at the Black African group, Black African men were 4.5 times more likely to die than white British men of the same age in the first wave. For Bangladeshi men, it was 3.5 times higher, and for Pakistani men, it was 2.7 times higher. So across the board, extremely much higher mortality risk. And then looking at the second wave, there's a good news story here in that the mortality risk for the Black groups has kind of reduced. And so what we saw in the second wave is that the death rates for the Black African and Black Caribbean groups were kind of at the same rate as the white British population. But unfortunately for the Bangladeshi and Pakistani communities, those death rates were still elevated and that mortality risk remained really, really high. So again, just to show you the numbers, for the Pakistani community, Pakistani men were 4.8 times more likely to die of COVID than the white British men of the same age. And for the Bangladeshi group, it was 4.1 times higher. So really, really elevated risk across both transmission and death rates. And one thing I did want to mention here actually, and one thing that's really important to remember is that there's Public Health England have done quite a lot of analysis on this. And it's not the ethnicity itself that causes these differing health outcomes. So it's not the fact that you are from an ethnic minority background alone that causes these disproportionate outcomes. In fact, what we've seen is it's a lot to do with socio-demographic factors and socio-economic factors. And that's what I kind of want to talk to you about on the next few slides. What has caused these differing outcomes for these groups? And so the first thing that we've seen is that there's quite a lot of evidence to suggest that the household size, the number of people that you live with, has an impact on your COVID outcomes. So on the left here, we've got positive test rates and death rates by household size. And so what I want you to focus on here is looking at how much more likely it is for you to get a positive test and for you to die from COVID if you live in a bigger household. So looking at that 11 plus category, if you live in a household with 11 or more people, you are 3 times more likely to get COVID than if you live in a smaller household of 1 or 2, and you're 7.5 times more likely to die from COVID. And so again, just by the household composition or the type of house you live in, the household size, that can really have an impact on your infection and mortality risk. So then relating that back to the ethnic minority point, what does that actually mean? How does that translate across? What we looked at is the proportion of different ethnic groups who live in large households. So on the right-hand side chart, just focus on that dark blue bar. And what's important to note here is for the white group, 3.5% of the white group live in households with 6 or more people in them. That compares, if you're looking at the Pakistani and Bangladeshi community, 36% of these communities live in households of 6 or more people. So just looking at the difference there, and even, I mean, picking out some of the other ethnic minority groups, they're much more likely to live in bigger households. That's one of the key reasons that has put some of these communities at elevated risk, because of their living conditions, because of the household size, and because of household composition. So that's one thing I wanted to kind of highlight today. The other thing when we talk about socio-demographic factors is occupational risk. And so what we've got on this chart is I've kind of listed from top to bottom the top 10 occupations with the highest death rates for men, COVID death rates for men. And so the restaurant managers and proprietors had the highest death rate for men throughout most of last year, and all the way down through to nurses. Those are the top 10. What you can see in the bars is the percentage of men who are working in these occupations and are ethnic minority. And then the dotted line kind of shows you what the average is across England and Wales. So anything that goes to the right of that dotted line shows you that there is an overrepresentation of ethnic minority men working in those occupations. And so on here, ethnic minority men are overrepresented in 8 out of the 10 highest risk occupations. That's huge if you think about it. So when you're talking about your day-to-day going to work, there are a significant portion of people who just by going to work every day are putting themselves more at risk because of the job that they do. And that's really evident, especially with the taxi and cab driver industry, with a majority of them being ethnic minority men, 56.75. So they are hugely overrepresented in a lot of these industries. And then now I want to kind of take it back to speaking about the vaccine and some of the data that we're seeing on the vaccine and vaccine hesitancy. The ONS have a wealth of data, but one of the really great things that they've done is they've got this survey where they asked for people's opinions on the vaccine. And one thing that they record is vaccine hesitancy. And we've looked at that data by ethnic group. So what we can see here is that over 4 in 10 Black or Black British adults reported feeling hesitant about getting the COVID vaccine. And that was recent. So this is from sort of mid-January to early February of this year. So that 4 in 10 compares to just under 10% for white groups. So that's 7%, around the 7% mark for white people. And even looking at some of the other ethnic minority groups, you can still see that there is a higher rate of vaccine hesitancy than there is for the white population. And so it's kind of those things that we're hearing in the news, and that's playing out in the data here as well. And then I also wanted to show you another bit of data which looks at vaccine coverage, the COVID-19 vaccine coverage amongst the 80+ population by ethnic group. So this is actual live data. This shows you exactly how many people have been getting the vaccine over the last few months. And what we can see here is the Black community are represented by the blue line on this chart. And vaccine coverage amongst this group is significantly lower than it is for the white group, which kind of sits at the top, just below that 100% vaccinated mark. And even for some of the other ethnic minority groups, the vaccine coverage amongst these groups is lower. And when we think back to, the risk and the mortality risk amongst these groups is so much higher than it is for the white group. So really, we should be aiming for vaccine coverage rates that either reach that the target for the overall white group or surpass it, because the risk is so much higher for these communities. And I've shown you the 80+ picture here, but actually it's the same for when we look at data for the 60 to 69-year-old cohort and for the 70 to 79-year-old. The story and the picture is the same across the board. And actually, one thing I did want to point out here is what we don't understand yet is what is causing the lower coverage rates. We don't know whether it's because these communities aren't being offered the vaccine as much, or we don't know whether it's because they're hesitant in taking up the vaccine when they are offered. or we don't know whether it's harder for them to actually access the vaccine in the first place. And so that is work that is currently underway to really try and pick apart some of that that understanding and try and figure out what's causing these rates to be lower. So that kind of brings me to the end of the data presentation, but I did want to summarize just by saying that, I mean, it's clear to see from all of the evidence that the risk is clearly much higher for the ethnic minority communities, and it has been throughout the entire pandemic, both from transmission and mortality rates when you compare it to the white British population. This elevated risk is largely a result of socio-demographic factors, like the occupations people work in, the houses that they live in, and the fact that a lot of these communities are more likely to live in more deprived areas. And so that's why it makes it so much more important for these groups to protect themselves and their communities by getting vaccinated. And just lastly, I wanted to say that all of the data I've used in this presentation is publicly available. I've put in links to each of the reports that the data has come from. So please do use this as a resource. You know, educate your family, your friends, colleagues who weren't able to make the talk today. Use it to share the right type of information and the most accurate information about exactly what's happening. Because I think sharing that knowledge is probably the best way of helping people to understand why it's important to get vaccinated. And that brings me to the end of the presentation. Happy to answer any questions that may have popped up in the Q&A now.
Thank you so much, Shivani. We've had quite a few questions come up, so I'll just pick a few of them. So one question that's come up is, thank you so much, Shivani. Is there insights as to improved mortality rates for Black African and Black Caribbean groups?
Yeah, that's a really good question. So actually, that's something that SAGE, the Scientific Advisory Group for emergencies, they've kind of got a subset or a sub-wing who just focus on ethnicity, which is really great. So that group is looking specifically at that question. They're trying to answer and unpick what has resulted in lower death rates for those groups. So it's a live question. It's something that they're still working on. As soon as we have more information, we'll be updating these sorts of slide packs and circulating them to our disproportionately impacted groups community. But yeah, so keep a watch out for that one.
And another question we have that's come up is, what is the causal effects of disproportionately high mortality rates in ethnic minorities?
I don't think I understand. Apologies, I don't think I understand that one.
The causal effects. Yeah, I'm not sure exactly actually about that question. Let me go to another one, and please feel free, if you want to elaborate more, to ask in the Q&A with that one. Another question that's come up is, why the Chinese group figures seem lower than other groups? Do we have any information on that in regards to that?
It's a good question. So I think from my understanding of sort of population concentrations, the Chinese groups tend to be concentrated in very specific parts of the country of England. And what the other thing we've seen is the way that people have been impacted is by the geographical nature of the pandemic and how much it's spread across the country. I don't have concrete evidence to say why it's been lower, but it could be the geographical nature of exactly the areas that this pandemic has hit that has meant that it's not impacted the Chinese group as much. But so case rates are lower amongst that group as well. I hope that sort of answers the question.
Thank you. And I think quite a few of these questions I know are going to be answered by a panelist. So let me pick one more. Oh, there was a really good one. There's a lot of thanks about the data, fantastic data. And people also want to know, are you able to share the slides publicly?
Yeah, so we've had sign off from our seniors in the task force to do that. So, and like I said, I mean, all the data is publicly available, and I've kept the links at the bottom. So, and you know, especially that open safely link. So that the vaccination chart, the vaccination coverage chart I showed you at the end, that is live data. So the link on that chart, if you take a look at that, it will update each week, and you'll be able to see exactly what coverage looks like amongst different age groups by ethnicity and by deprivation and by many other cuts. So please do keep a watch on that. And I'm happy to answer any other questions throughout if people have more.
And I think the last question we have is people have asked if any of the data has been analysed by religious aspect. So I know there's a lot of sometimes hesitancy in different religious groups. Has data been analysed in any ways there?
I'll be honest and say it's really difficult to get a hold of data by religious groups. I mean, getting data by ethnic minorities was extremely difficult. But one thing we have done is we've spoken to community leaders quite a lot in as part of our role in the task force, because we do understand the importance of kind of how people's faith interacts with a lot of the ways that that this pandemic has been playing out. But that is definitely an area that we want to explore a lot more. But yeah, that's a good question.
Okay. Oh, and one more question actually that might be a good one before we go into our next part is, do we know why there were less infections and deaths in Black men during the second wave? And could this play a part in why people from that community might be less reluctant to get the vaccine?
So in terms of the reasons why, that's still something that SAGE ethnicity group are trying to uncover and unpick a little bit more. And as we understand what some of those reasons are, I think it will be kind of important to try and communicate that to people in different ways. But unfortunately, I don't know more about that yet.
Thank you so much, Shivani. That's been really helpful.
I've actually just seen one question that it might be helpful to come back on. It was on the reasons why vaccine hesitancy was higher amongst the Black communities. And some of the reasons that that came out of that research was because they were sort of unsure about the longer term implications of getting the vaccine. So that was one of the major reasons that came out of it. So yeah, that might be something to explore as we continue this event.
Thank you so much, Shivani. And now I will talk. I haven't had a chance to introduce myself. So my name's Abigail J. I'm a senior policy advisor in the community engagement team, and I'm also head of events and communications for the Ministry of Housing, Community and Local Government's BAMEnet. And I actually work, like I said, in the community engagement team, and part of the work we do is engaging with community champions. So we're really engaging with Black and Asian minority communities, organisations who are doing the groundwork and really engaging with communities and the hard to reach areas. So we think that's like hugely important work. And before I pass over to our esteemed panelists, I just wanted to show some of the data we've been getting within our network. So I'll share the slide because we've been asking our networks how they're feeling about the vaccines. So hopefully I'm going to be able to share my screen. Not the entire, oh yes, the entire screen. So hopefully everybody can see this.
Yeah.
Can you give me a thumbs up? Everyone can see that? Yeah, brilliant. So we've been engaging with our network. We've only recently sent this out just to kind of find out the information about how people are feeling. And these are some of the questions we've asked. So we asked, if the COVID vaccine was offered tomorrow, would you accept it? And of the majority of people who have answered so far, the majority are saying yes, definitely. In regards to the people who were unsure, the most common reason that seems to be coming up in regards to the concerns is that they're waiting for other people to take it. In regards to what would make people feel more comfortable about the vaccine, so far, and we're continuing to get the data, people seem to want more information about the side effects. We're hearing that most people get their information from the news, and the following statements that best describe some of the main reasons that people want to get the vaccine so far does seem to be to protect themselves against the coronavirus. And yes, we've been engaging with, generally it seems to be the information they're getting about the vaccines is positive. And we've been making sure to kind of collect the data to find out where we're reaching out to people. So that's some of the information we're picking up at the moment. And we do continue to ask all people in our department, BAMEnet members, to fill out the survey, and we're happy to kind of pass the survey questions we've put out for other networks that want to engage and kind of find out how their network is feeling. So that's just a little bit of information from our side. I'll now stop sharing the screen and I'll pass over to Roxana Hini, who will be introducing and chairing the panel session with our esteemed panelists.
Thank you, Abby. So it is my absolute pleasure to introduce four really eminent medics. I could spend quite a long time because I've got a really great briefing with all of their qualifications and experience and background, but you will have to bear with me and I will just give you the highlights. So firstly, I'd like to introduce Professor Fenton, who at the start of the pandemic stepped into quite a pivotal role in Public Health England in London, and then quite quickly did a really important, and I feel from a civil service perspective, really seminal piece of research looking at the where there were disparities. It's a report called Beyond the Data. I know it was discussed a lot in the civil service last year, and I know it was also in the press and in the media, and it really helped to create a really strong dialogue. So welcome, Professor Fenton. I'd also like to welcome Dr. Macaulay. She has over 25 years experience as a haematologist and an oncologist, having trained both in the UK and in Nigeria. So welcome and thank you very much for joining this panel. I'd then like to introduce Dr. Adesara, who over the last year has been really active in terms of like frontline treatment on COVID-19, but even going beyond that and really being a really strong advocate in the media and in social media, particularly around BAME communities. So thank you for all that you do there. And then last but not least, Dr. Griffiths, who is a clinical lead for trauma surgery at St. Bart's Health. You may have seen him in the media. He has been really advocating quite strongly for the vaccine, even though it's not really his main specialist. So you may also know that he does a lot of work in London advocating in BAME communities around violence. And as a mother of young Black boys, I do hope never to come across him in his professional career, because he does such amazing work in that field and tries to make sure that he reduces violence over and above what he does in his core role. So I'm going to start off with my first question being, how come it takes so long usually to produce vaccines, but these vaccines have been produced in such a short period of time? If you were reading any of my WhatsApp groups from my family and my minority communities, there were lots of questions about, are we being guinea pigs of something that's so new? So would anyone like to step in with that first question?
I can take that. Thank you for inviting me. I said I can take that because in my professional life, I did work for AstraZeneca and I'm a member of the Faculty of Pharmaceutical Medicine. So we do drug development, vaccine development. Yes, it's taking such a short time because the bureaucratic bottleneck that you have during drug development or vaccine development has been taken out. And what do I mean by that? Usually when you are doing vaccine trial or clinical trial, you need a lot of cooperation, you need money, you need to do phases of development, phase 1, 2, 3, 4. But for this vaccine, the world came together. So you find that the scientists in the lab that are doing all these tests, instead of now trying to apply for grants and seeking for money that might take years for it to come, they actually got the money quickly. Another thing about that, so they had the provision of the money, the phases of the trial were done in parallel. So as we were doing animal trials, they were doing trials in human beings. So at the same time, they were doing things that we would have done stepwise. The third reason is the regulators that are supposed to review the package. So you do the animal experience, you do the experience in man, and then the regulators will look at your package and see if the risk and the benefit is actually worth it to approve this drug. And you find out that because it's a pandemic, all the regulatory authorities came together to review this package in real time. So instead of waiting for you to finish this step before the review, they were reviewing and they were carried along as they go. And of course, because of that, the time was shortened. So there was no cutting of corners when it comes to safety of this vaccine. It was just collaboration and efficiency of science.
Excellent. Yeah. Thank you very much for that clear explanation. Come in, Dr. Adesara.
Yeah, I think I can just give you a bit of my background in that. For the past year, I was been working in a London hospital. and saw lots of COVID patients. But then the past 2 weeks, I've just started a new job in general practice. So it's sort of the other end. And then we're having a lot of conversations with people about vaccinations. And this is a question that comes up a lot about when people are concerned about the vaccine. And it's a really legitimate question. I think it's quite logical. I think even sort of I think medics and healthcare professionals thinking, oh my God, it's very, very quick. So I think actually what Grace just did there, explaining that no corners were cut, and we have a very stringent process in this country of how we when we look at medicines and vaccines, none of those corners were cut. And as Grace said, things that normally would happen one by one, some things are happening in parallel. So I think explaining that to people is really, really important, and taking time to explain that is really important as well. And I think people then can understand that certain steps took quicker. So, recruiting people to the trial, something that can normally take a very long time, trying to recruit the numbers of people that you need for medicine trials, in this case was very quick, because we had, thousands of people just volunteering. So I think, explaining this to people, if you do take the time to explain it, my experience has been that actually then people do understand, oh, okay, that does make sense. Funding, we didn't have to, the government's gave a lot of funding to vaccine production. So explaining it, I think it's actually a really logical concern, and then explaining it as Grace just did, I think, I found can alleviate people's concerns.
Excellent, thank you. Actually, can I ask you to continue then when I come to you on the next question? Maybe you're answering this often at the moment as a GP. Can you explain the different types of vaccines? And also, are any of you able to come in, particularly on the debate at the moment on blood clots and concerns there?
Okay, I'll go first to the blood clots question, because there's quite a simple answer to that. So the number of blood clots that they've seen haven't been higher than what we'd normally see in the general population. And today, I know there's been over the past few days some European countries raising concern, but actually the European regulator have announced today that there isn't an increased risk of blood clots from the vaccine. So I think you can say that quite categorically to anyone that has concerns. With COVID, if you get COVID, there is an increase of having blood clots, and that's because that's through the process of your body's immune system reacting to the virus. And actually it's something that it's been a cause of death that, I've seen it a fair few times actually over the past year, that people dying from blood clots in their lungs, often from the virus. So I guess if people are concerned about that, the best way to protect them is having the vaccine to protect themselves from getting the virus, because there is an increased risk of blood clots if you were to get the virus.
Thank you very much.
Can I just add to that on the blood clots? My department is what they call pharmacovigilance or patient safety. That means we review the data when drugs are being developed, and we try to find out why some events happen. And if you look at the data from AstraZeneca, you find out that they had 15, and that would have come to me if I was still with them. So they had 15 of these people having what they call DVT, deep vein thrombosis. That means clot in your leg. Now, and they had 22 people with the clot in the lung. But if you take it's always about risk and benefit. If you take those numbers and you equate it to so many millions that have had the vaccine, then you see that the number in our case, we say something is very rare if you get 0.001. Now, if you take 37 cases to 22 million, I mean, I don't even know how many zeros I will put. So because of that, the authorities, like MHRA, the Medicine and Regulatory, they're saying it's very rare. So they can, and they've looked at all their data, it's not linked to the vaccine, but per chance it is, because we never want to say never until you have your final data in medicine, and the final never comes. Per chance is going to be very, very rare. So the risk of dying from COVID is actually higher than the risk of you having the clot and living longer. I just thought I need to put that in perspective. Thank you.
Yeah, and to add, we have a yellow card scheme. I don't know if you're aware of that. So anyone, let's say, someone in the clinic had a vaccine and then thinks that they're having a side effect from the vaccine, and they let us know, we are then obliged as healthcare professionals to document that through the yellow card scheme and inform the regulators. So all potential, sometimes you don't know if it's linked or not, but all potential side effects, we have to document it and inform the regulators. So all these things are being recorded.
And Roxanne, if I could come in here as well, just to reflect from the London experience. I'm the Public Health Director for London, and we are really pleased that nearly 3 million Londoners now have received the vaccine, and we're actively looking at the data to look at side effects. And I'm really pleased to say we have not seen any cases of clotting associated with those who've received the vaccines in London, and we're working with the MHRA and colleagues to ensure that we continue this surveillance. So it comes back to what Grace and Sonia have said, which is the risks of clotting are very, very, very low, and protecting ourselves, getting the vaccine, and ensuring that we're helping and working together to reduce transmission is really our top priority now.
Next, I'm going to come to Dr. Griffiths. I've seen you speak on TV quite passionately and being a really strong advocate. Tell us about your own personal experience with the vaccine, but also noting what we've been hearing about vaccine hesitancy, particularly in the Black communities. Are there any concerns or issues that you've heard, and can you reassure us in any way?
Yeah, thanks. Can you hear me all, guys? So COVID's a beast of an affliction, and I work in East End of London, where COVID is rampant in Tower Hamlets, and I live in Redbridge, where it's very, very prevalent. And I got COVID in the first wave, and it wasn't it was something I would never ever have again. I thought at a point I thought I was going to die. I've had friends who are clinicians who were ventilated for weeks with COVID, and they were fit, healthy people. And when you go to my hospital, which is a big teaching hospital, which normally has an intensive care unit that can ventilate, put on support, maximum of 40 people, and we had to build 2 extra floors, ventilated patients, ventilating 250 extra people on ventilators with a bed capacity of another 700 people with COVID. You recognise the size of the problem. This is something that is killing healthy people on a regular basis. Yes, we know it normally affects people who are older, and there are some demographics around it, but this is an illness that kills people who are healthy as well. And when I had COVID and I recovered from COVID, the thing I promised myself and my family that no one would ever get it. And when my clinical practice stopped for vascular surgery because of COVID, I couldn't do any operating. I had to do something with my time. It was I nursed on the wards. I elected to spend time vaccinating because I could see that this was the only way to get our community out of this hole, because lockdown isn't working. Social distancing isn't working. It's got no legs on it. It's not going to last forever. We have to find a way to get that immunity into our population so we can go back to our normal lives and be prosperous and safe. And that's the only way by getting that immunity up there. And either having COVID, which gives you potentially temporary reprieve from that immunity, or having a vaccination that is effective and safe, okay, is the only way to move these things forward. So I became very, very, very interested in finding out the data. And as like all people who are healthily skeptical, I looked at the data and asked the questions. And I absolutely recommend everybody to look at the data and ask those questions. It's about being reasonable and asking reasonable questions. And there's nothing wrong at all with asking those reasonable questions and getting good information from the right sources. It's about when you take your information from sources that are untrustworthy and are not presenting the actual facts, or skewing small bits of data in the wrong direction, you lose sight of the clarity. So back to my experience. As a clinician, I chose to start vaccinating because I thought it would be the one thing I could do in my clinical time to help promote the issue. And I found that there was a big uptake among people, but there was a big disparity. And my Black colleagues and were less interested in taking up the vaccine. And when I spoke to my own family in Southeast London and the Caribbean, they were said to me, well, there's all these things going on about it's going to make me sterile. And I said, where are you getting this stuff from? Is it from your GP, etc.? And I said, no, I'm getting it from WhatsApp groups, or from my friends, or from my pastor, or from so-and-so. And I said to myself, well, guys, hang on a second. Talk with me about this. Let's talk through the issues ourselves. Let's go through them one by one, and I'll show you the data. And this is about having reasonable conversation with people who want to be supported in making reasonable decisions. It's not about being told what to do or being patronized or being dictated to. And one of the things I've learned about the whole vaccination process is that the vaccination itself is safe, it's very effective. I have the vaccination myself, I have the 2 doses. My antibody levels are fine and I'm good. I'm in the right place in that regard, and I can now return to work and to my life, and I'm not going to spread COVID to anybody else as well. What I realised, there was a big issue around about trust, the way in which the communities who I serve in my violence reduction programme feel disenfranchised. People of colour have traditionally felt disenfranchised, not part of a society, not part of authority, never allowed a voice in this space, or the information in a way that's palatable, accessible. And there's an inequality of access and experience and outcome in lots of ways of life. And COVID exposes that inequality piece. It exposes the fact that people feel disenfranchised and are not allowed to voice concerns about being branded as being laggards, or being difficult, or being skeptical or hesitant. It's asking reasonable questions of things that affect people in a significant way. And when data is presented, you can have a reasonable conversation. And my mission, my passion here is to make sure that people have that space to have conversations with trusted individuals who can present data objectively, talk through issues, okay, answer questions reasonably, and move things forward. I'm not going to tell you what to do, okay? I'm going to give you the information, allow you to make your own decision about it, and I'll respect your decision, be it yay or nay. What I will do is make sure the information I give you is up to date, accurate, and presented transparently to make your own decisions about things. Where we've had issues with people who have been concerned about the backstories of companies in the past, about how they felt treated by society, how they feel they're being tested or demonized for not being part of the program, and that's not the issue. What I've absolutely been very clear about this is that the communities that I work in and serve are quite right in this, to be clear about what's going on, and I'm absolutely passionate to make sure that the information we give to those groups, okay, those people, with me and my family, is clear, transparent, accessible. And should you want to have a conversation, have a conversation in a way that's comfortable to you. And when you choose to have a vaccination, it's available to you in a place of comfort, ease, and suitability towards you. So you can make sure that you get vaccinated at the time of your choosing which is more appropriate for you, the place you feel comfortable with, and that we know that people you trust are giving you information that you can be absolutely reliant upon. And that in place, not only can we deal with COVID, we can actually start looking at our society in a better way, because I think there's a real opportunity here, a massive opportunity here for people of colour, okay, to actually have a better conversation about how we engage in our health discussions, how we engage in our society, and how we can reconnect with the authority that we're sceptical about. I understand there's a whole load of concerns about how people of colour interact with our society, but I believe now, by recognising there's a disparity there, and actually working together to try and close that sort of knowledge gap, that gap of concern, we can move forward and engage the communities to actually design and own solutions to problems. So this is not just a solution for COVID, but this is actually a way for us to move forward as a community, you know, within a great city and country. So I'm really excited about this movement forward, and I'm glad to be asked to answer this hard question. So thank you very much.
Excellent. Thank you, Dr. Griffiths. You've actually answered my next question. So I'm going to move on to something else, because actually my next question was actually about how we talk to our communities. One particular person had said, most of my aunties and uncles in the Goan community don't listen to me because I work for the government. Well, I think you've just answered that question there. Thank you. So my next question actually might be more for Professor Fenton, but also I think it's one for all of us. It's a question that's come up on Slido. And the question is, what are you doing to address the systemic issues that result in poor health in our communities that lead to us being more vulnerable to COVID and other illnesses? Though I also think that's something as civil servants we also need to be considering as well. But Professor Fenton, what are your thoughts?
Yes, well, first of all, thank you, Roxanne. It's what are we doing to address these systemic issues? Because it really does take all of us working in every part of the civil service in the community to begin thinking about how we address many of these underlying issues which are driving the inequalities that we've been discussing today. So, you know, one of the key aspects of the pandemic is that it has really shone a light on long-standing inequalities, and it has worsened inequalities as we've been going through the pandemic over the past year. And the pandemic has really brought to the fore that the jobs that you do, the housing that you live in, the ways in which you're connected to your communities, the engagement that you have with authorities can have a huge impact on your health and well-being and your risk of acquiring COVID. So as we emerge from the pandemic, I think the key question then becomes, how do we move beyond thinking about health as purely access to high quality healthcare provided by the NHS, but ensuring that all of us have a stake in accessing and taking up those services, and we begin thinking about some of those wider determinants of health. So job opportunities and quality and the environment that we're working in, the ways in which we're connected to others in our community and society, the ways in which we support better housing, the ways in which we support physical activity and mental well-being, both of which have been shown to be risk factors for having severe disease and dying from infection. So I think the pandemic is showing us the need to broaden our understanding of what drives health and well-being, and to work across partners to address this. And then finally, just to reflect again on what Martin has said, the opportunities for us to really use these engagement sessions that we're having with communities, what we're doing now in COVID. I've been in public health for 25 years. I have never seen the types of engagement, the types of conversations that we're having with communities in my entire career. And this is the foundation for a new way of working with communities to address these long-standing issues. So again, it's moving beyond just thinking about access to healthcare, but really working together to address those wider determinants of health.
Dr. Kutsala?
Yeah, I think I just agree with every word that that Martin and Kevin just said, and I guess the point that I'd like to emphasise is that I work at the moment. The hospital I was working in was Edmonton, and the practice I now work in is Tottenham. So it's a multicultural area. High levels. Quite a lot of people living in quite high levels of poverty. Lots of high immigrant population, and I guess this is. If you look at our GP records, that if you look at vaccinations, not COVID, but sort of other vaccination, immunization, children immunizations, flu vaccinations, if you look at things like people getting their diabetes checks, people getting their blood pressure monitoring, all these normal health condition monitoring is something that has been historically bad amongst certain communities where I work. So this is something that we've known about for a very long time, and this is why it's so important that we have public health and good, well-funded local public health teams to address these inequalities and put in the additional resources and the additional programs and the outreach programs to try and reduce these inequalities. And that's something that we've really, public health capacity and resources has been dramatically cut in recent years, and we've seen the impact of that where we've seen the inequalities between certain groups widening over the past few years, and you do see that. And it's really interesting for me because I work in an area that's quite deprived, where my sister, she works literally about maybe a 15-minute drive away from where I live, so it's sort of the same area, but the population demographic is different, and she has a completely different job. So it's something that, as I said, it's good that we're starting to sort of see the importance of this, but actually anyone working in primary care would have known that this was going to happen, and would have known that certain groups would have poor uptake of the vaccine and generally have poor health. And for me, it's just quite sad that not enough was done in the run up to this to try and put those resources in to try and reduce that. And right now, in my practice, there's a lot of GPs and nurses' time being spent calling people up. Patients are calling in, talking to them about the vaccine, talking to them about their concerns, legitimate concerns, answering their questions. But that's kind of time that's coming out of their normal clinical time. So the GPs are working, longer hours, but it's coming out of a normal appointment time. And as many of you will know, actually, GP in primary care is really pre-COVID been really struggling. So what we need from a sort of a policy point of view is that thinking about particularly areas where we know that there is lower vaccine uptake or maybe more hesitancy, we do need more resources to allow healthcare professionals to have these conversations with communities. So where I work, we have some GPs from different communities actually, who are then in their spare time, in the evenings, in the weekends, in their lunch times, going out, having community groups, talking to them, but they're doing this all in their spare time. And ideally, that should have been done in a more structured way, and the resources and the money should have been put into that.
Thank you. Can I just add to that? From my experience while I was at King's College Hospital in the 90s and 2000, now people will be guessing how old. But I just want to say it's not just about the effect of infectious diseases. It goes beyond that. It's all about dieting, it's all about way of life. I mean, I used to go around churches when I was in London, just talking to them about sickle cell disease, about breast cancer awareness. And even when I moved out of London and now in the pharma industry, I keep on doing that. So I think the onus is on all of us. It's not just the healthcare workers, but all of us. It says if you want to hide something from, pardon me, I have to say this, if you want to hide something from a BAME community, or should I say a Black person, just hide it in a book. And even if it's 1 million pounds, and they won't find it because they don't want to open the book and read it. And I just want to say the onus is on of us to, you said, education, to educate ourselves, not just from what the media. There's so much in the media, but we can just go to the NHS website, go to the CDC website, go to MHRA website, and there's simple instruction there about mammography. I was talking to Benedict about it. I even have nurses, healthcare professionals who will receive letters for this that you're talking about, and they will not go. So it's all about everybody owning up that is left to us to take responsibility that the health in our community needs to be better.
Thank you, Dr. Griffiths.
Yeah, echoing the points that have been made beforehand, I think there is a real opportunity to actually own healthcare. I think the sort of transactional prescriptive thing that I tell you what to do, you do it, went out a long time ago. And health and well-being isn't about tablets and about injections. It's about recognizing your own vulnerabilities. It's about taking care of yourself. It's about asking the difficult questions and about being engaging in your own well-being. And I think that the tendency to be passive has to go now. I think that we're in a situation now where people are actually asking questions, and that's fantastic. That people in the community are seeking out information, they're asking questions, they want to know what's going on, and we're actually listening now, okay? And we can change that paradigm completely. We can now say, yes, what do you want to know? What do you want to do? How can we change your healthcare to suit your needs and make it bespoke to your community and your particular requirements? And that's where we're going to go, because we can make healthcare. It's not just about the medication. It's about how you access care and how you experience care and how you choose to engage yourself in that space. And we're in a situation now where people are actually asking those questions and are getting reasonable answers. And the bridges we're building now aren't temporary. They're forever. You've got people who are trusted, who are passionately care about these communities, okay, about you, about our families, about the nation's health, and we're prepared. We've made those bridges so we can all walk across them and communicate. Because the NHS isn't just somewhere I work; it's where I live in this community. Okay, it's my community too. It's my family too. This is our world, and we're now in a space now where we can have the communication and have those conversations every single day. So my recommendation, and it's my advice, is to ask those questions, be challenging, be part of that question, and let's build a better healthcare system which is more responsive, more humble, okay, less hierarchical, okay, and much more effective.
Yeah, I'll just add to that as well. Like, I think, the primary care model for a while now we've known it doesn't work, in that you have these 10-minute appointments. Often people come in, with people's bodies are complicated, and I think GPs and patients know that when they come in and they say, look, I'm stressed and I've got my blood pressure's high, or I've got high blood sugar, and I think what a GP can do in 10 minutes often is just give a medication or give a pill, and give them a patient leaflet. And actually, I think both GPs and both the patients know that actually, no, this is not enough. And I think, Martin is really spot on there. Actually, there's a lot more to being healthy than just taking medication. And I think a lot of patients sort of realize that, and are becoming a bit skeptical about medicines, kind of rightly so. And I think we do need to think about our model of healthcare delivery. And I think this is obviously a different talk, but thinking more about how people can be empowered with the right information to live healthier and have healthier lives. And to be honest, I don't think that quite works in the sort of 10-minute appointment model that we currently have. But I think we do need to be thinking about how we can make healthcare more, we use the word patient-centered, but essentially talking about how we can make people more empowered around their health and having a more holistic way of doing healthcare, which at the moment we're still quite paternalistic in medicine and still very reliant on medication and not seeing people as a whole. And I think that's where some of the skepticism comes in medicines.
I think your point is very well made, and I expect we've got colleagues from DHSC, and I hope you're acting on that tomorrow morning. So I'm going to go back to the next question from Slido, which actually goes back to your point about actually being informed. So the question is, how much do we know about the long-term implications to our health? Is there a chance that the vaccine could make you infertile, cause blood clots, or be a risk to cause other types of health issues?
There is no theoretical or there is no biologically plausible mechanism in way that the COVID vaccine could cause infertility. And there has been, we have in previous vaccinations, fertility has not been an issue. In previous, the mRNA vaccine, which, the Pfizer vaccine, even though that's a new technology it is a technology that's been used in clinical trials for some other vaccines. And again, there's been no concerns about fertility. So I think and I know this fertility thing is a concern that a lot of communities and a lot of people are concerned about, but there just isn't any plausible way in which the vaccine could cause problems with fertility. I think maybe it came from the fact that pregnant women, we're not routinely vaccinating pregnant women. The reason why we're not doing that is because when we, in this country, when we routinely vaccinate, when the government, the MHA say that we will routinely vaccinate a population, it will only be done once we have done the trials and we have good data to show that a huge number of people have been vaccinated and shown that there's no side effects. In the trials that were first done, pregnant women and breastfeeding women were not in those trials in high numbers, so we don't have a lot of data yet on pregnant women. Having said that, there's no reason to be concerned that the vaccine should cause any problems with pregnant women. And if a pregnant woman has she's got some severe health problems, or if a pregnant woman is working in a high risk occupation where she'll be exposed to the virus, then she can have the vaccine, and that's a conversation that she can have with a healthcare professional.
Thank you.
And same with breastfeeding as well. Yeah.
Oh, brilliant. Good point. Thanks. I'm going to come to you next, Dr. Griffiths, on the next question, because you had said that you'd had recent experience and colleagues as well. The next question says, is it not true that a healthy person with a robust immune response when contracting COVID recovers from illness in a similar way to which they would with flu?
So I wish that was true. I wish that, you could get flu and be absolutely fine, but people die of flu every single year, and one of my friends is a triathlete. He's the fittest person I know. And he got COVID and he was nearly ventilated. You can't predict who will be affected by COVID. It doesn't matter if you eat all the right vegetables and live the right life. If you're unlucky, you have a cytokine storm, there you are on a ventilator. And it's, yes, there are things that make you more likely in terms of age and your body mass index and other medical conditions, but there's no absolute guarantee that you won't be that one. And if it's 1 in a billion, if you're that one, it's still you, isn't it? And I think that we have to recognize this is a condition, okay, which is highly transmissible, okay, and kills healthy people. We have an extremely effective, okay, low risk vaccination program that can reduce your risk of transmission and illness dramatically, which is widely available and free. So what's the way you want to live your life? Do you want to make an active choice to take something that's safe and will reduce your risk of transmitting or contracting COVID? Or do you want to take your chances, get the disease and probably survive, or give it to people who is more vulnerable by transmitting it, okay, and then contract COVID in the future? Because there's no guarantee when you haven't had it once, you won't have it again. And if you want to play Russian roulette with your life, that's absolutely fine. But if you've got ailing relatives or relatives who are older or people who are medically vulnerable, those activities put the whole community at risk. And I'm not trying to scare or threaten you, but you have to recognize that if you are without symptoms, but you're transmitting this bug, you can give to people who are much less able to deal with it than yourself. So yes, you have a responsibility to yourself and your well-being. You can make choices about you, but you have to protect your family and your friends as well. So I think being responsible, looking at the information, asking the questions, and making the choice that is right for you and your family makes total sense. But no, there's no guarantee. Just because you're healthy, you're not going to get COVID and get very ill with it.
I'll just add, I've been working. Yeah, I've been working in hospital medicine for 6 years now, and every winter we deal with flu, but never before with flu have I been seeing 40-year-olds being put on ventilators. It just doesn't happen. COVID is very different. And we had in the hospital that I work in, one of my colleagues, he was 50 and he died from COVID. 50 is very young, and no sort of health problems he was aware of. So it is different. I really get so angry when I keep hearing people, say, "Oh, it's just like flu." It's not like flu, and it can hit people very differently. You can get 80-year-olds with no symptoms, and you can get fit 45-year-olds who are coming into hospital because they're struggling to breathe and need oxygen and they need extra treatments. So I don't, it is a serious illness. I just wanted to add that.
And I agree. I was just going to add that the other sort of myth and misinformation circulating that it's not, if I'm a younger person in my 20s, 30s, I don't have to worry about COVID. And while you may not see the level of severe disease and death in younger ages, what we are seeing is the appearance of long COVID. So people who've become infected with COVID and then develop long-term symptoms, shortness of breath, lethargy, sometimes a sort of mental fog that are not as sharp as they used to be because of how the virus is affecting different organ systems. So, we all have a role to play here, not only in acting together to reduce transmission, but recognizing that if you're old, you may have particular outcomes. And even if you're young, you may have particular outcomes as well. So we all have a role to play in both protecting ourselves and others from transmission as well.
Thank you. I'm going to give my final question to Dr. Macaulay, and while she answers that, I'm then going to come to each of you because there are many more questions I could ask you. I'm going to ask you each to come back on what one message you would like to take away. So the next question, Dr. Macaulay, I think this might be more related to you. It says the pharmaceutical companies providing the vaccines have been given indemnity exemptions. Why is this, and do you think this is affecting the uptake of vaccines?
Thank you for the question. I think it's affecting the uptake because people think the pharma companies cannot be sued because if they make a mistake with the vaccine, and that's why they've been giving this indemnity. But even though there is no data or there's no information about that, the most important thing we need to recognize is that has been given because we are still going through the process. Even when the drug, don't forget, they have been given approval. It's a conditional approval. It's not a full approval. So that means they continue to gather information about the event. And because of that, they cannot be liable for something they don't know because there's no data to support it. And that's why they put that in place so that somebody doesn't sue them like 10 years to come and say, look, I developed 2 double heads because of this. And that's why that's put in place. If they don't have the data, they cannot present it. And somebody can sue them for it. We all know in America that happens. I think that's why that is in place. But it's not in place to hide anything. I think I need to point that out. It's not because the government is siding with the pharma company to kill everybody as we have it. That's the rumor that's been going around. No, that's not why they put it. It's not to hide anything. Everything is transparent. It's just because as long as we are still developing this drug and we are having what we call data for years to come, because we are still going to be collecting data years to come, they need to be protected against somebody just suing them for what they will not be able to have a data to support it. That's my take on that.
Thank you. Before I go to others, is there one main message you would like everyone to take away, Dr. Macaulay, from this session?
Yes, please. I've had mine. I'm 60 plus and I've had mine. I don't have any underlying condition. I'm not working in the hospital again, but everybody that's close to me, they know I've been to, I don't know how many churches. Dr. Benedict got me through one of the programs in the church. My motto is always prevention is better than care. I mean, than cure. Another thing is knowledge is power. The Bible that I read says, my people perish because of lack of knowledge. If there's one thing I want everybody to take away today, please do not be selfish. If you do not have the vaccine, then all of us cannot be protected. The herd immunity we are trying to generate cannot be achieved if my neighbor doesn't take his or her own vaccine. And so I just want to say, please, this vaccine is being developed, is safe. This is what I've done for 25 years, drug development, cancer treatment, hematology. Chemotherapy is worse than this vaccine. Come and ask me, cancer treatment is worse than this. And yet we give people because it's about risk and benefit. Do you stay alive, or do you let the virus get you? Please take the vaccine. Thank you.
Thank you, very well said. Dr. Griffiths, what would be your message for us?
I could give two because I'm greedy like that. The first thing I would say is that this is an opportunity for every person in our community to actually actively engage in their healthcare. Not just COVID. This is about us recognizing we have a responsibility to our own well-being to ask those questions, have them answered, and engage in our care to design what healthcare can look like. And we're now open for business to have that conversation. The thing I'll say is a bit glib, okay? When you read information on the internet about COVID, okay, imagine it's April the 1st and read it again. That's me done.
Very good point. Dr. Adesara, what's your main point? What would you like us to take away?
I was just going to say, for Grace, my Indian granddad always used to say, knowledge is power. So maybe that's that's a good take-home message from all of us. But I think, agreeing with Martin that we've known for a very long time that people in our community, some people living in our communities have poor health. So this does need to be having, I think, an opportunity for us, yes, to take ownership of our health, but also to have a sort of a serious, serious consideration of how we address those inequalities. And I think we need to be giving more money and more staff and resources to Professor Fenton and his team, because actually public health is really important. And we do need to be, to all your policy people watching, we do need to be investing in public health and seriously addressing health inequalities, not just in the pandemic, but we need to be thinking about this all the time.
Excellent, thank you. Professor Fenton.
So I think my takeaway message is really just a bit of a reflection just on how hard this year has been for us. None of us expected to live through a pandemic of this sort, of this nature. And certainly none of us have expected our friends or family members or colleagues either to have been infected or to have died from this disease. And now we have what I think is the most powerful tool to protect ourselves and to protect our loved ones and the community, and it's the vaccine. And as we prepare to unlock again, to lift the lockdown, and we're on the roadmap and we're reopening society, I want to ensure that all of us have the maximum protection that we need to be able to re-engage, restart in our communities and to begin rebuilding our communities. And getting the vaccine is going to be a key part of that, in addition to hands, face and space and everything we've learned in the last year. But let's use this opportunity. It's amazing that the government has been able to procure the vaccines. It's fantastic that they're so safe and effective. Let's all get informed, make an informed decision, and protect ourselves and our communities.
Thank you. That was a brilliant final message, actually, from all of you. Can I just say, from myself and from 231 colleagues who are online, thank you so much for giving your time, both to advise us in terms of us individually thinking about our families, thinking about our communities, but also noting, I think there are some points there for us in terms of policymakers, thinking about what is our role, because actually many civil servants have been quite heavily involved in policy. We need to speak up. We need more great people like Shivani bringing out the data, challenging, making sure that we're following that data, and also listening to amazing experts like yourselves to make sure that we are developing and trying to deliver better policy. So thank you very much for that. But also a heartfelt thanks, because as Professor Fenton said, this has been an incredibly hard year. And actually, I know many civil servants are frontline workers, but also many of them are like myself, who are fortunate to have the ability to work at home, and you are all going out and vaccinating and working in GP surgeries, and then in the evening advocating to our communities. So thank you so much for all that you've been doing. We genuinely appreciate it. And now I will hand over to Bernadette, who will talk about next steps. Thank you.
Well, thank you so much. Absolutely brilliant. Honestly, I'm ever so proud. And thank you, panelists, and to everyone on the phone, on the call, all 228 of you still here. Our panelists just said yes. They just said yes. We'll come. It's for the community, and they didn't ask to be paid. We reached out to some others who asked to be paid, but our colleagues here with us today did not take a penny from us to really empower us and dispel some of the myth around the vaccine hesitancy. Thank you so much. Shivani, from unpacking the data, absolutely brilliant. Professor Kevin Fenton, Dr. Sonia Adesara, Dr. Grace McCauley, Dr. Martin Griffith, thank you so much for your time. We know your time is absolutely valuable, but you've taken the opportunity to empower the community and educate the community. To all my colleagues in the back room, pulling this event together at pace, to Abigail, to Roxanne, to Kathy, to Umi, I think to Alan in Kathy's team, to Dave, who is the Zoom, the man on the Zoom. He never says no to us, you know, last minute, he always shows up. Thank you, Dave. And to everyone out there, so I've posted something in the chat, an event in the chat, and we know, thinking about this event, we're really glad to see an event by our colleagues in Bays, because we know for some reason or the other, some people might need to hear a message more than once. So tomorrow there's a similar session put on by our colleagues in Bays. I've dropped the Eventbrite in the chat. For colleagues who are unable to do the evening session, they're doing an afternoon session. So look, we've catered at the community within the civil service for everyone. So look, guys, as I begin to close, I have to say thank you again to our panelists. We've got some information. I know people have been asking, are we going to get the slides? Dr. Grace has sent me stuff. So we'll package everything together and send it to everyone who's registered. But look, you've heard the final messages from our panelists. This is absolutely critical for our community in particular. When you get the call, if you're of that certain age at the moment, you'll be getting the call. I haven't had mine yet. I need some tips on not being scared of needles. I'll come out to the panelists privately. I'm very scared of needles. But when you get the call, please be the first person booking your appointment and tell all your friends and family. There are about 400,000 civil servants, about 52,000 are from the BEM community. If all of us go out, we can all make a difference. Thank you all and goodbye. Have a great evening.